afternoon. My name is Sanaz Masumi. I'm the Chief Operating Officer at the Patient Safety Movement Foundation. This webinar is brought to you by our foundation and in honor of the World Health Organization's World Patient Safety Day, which is celebrated every year on September 17th. This year, the theme is Engaging Patients for Patient Safety. This is to recognize the crucial role of patients and families in the safety of healthcare. Through their slogan of elevating the voice of patients, WHO brings attention to the fact that patients should be involved in policy formulation, governance structures, design of safety strategies, and they should be active partners in their own care process. Healthcare is a multifaceted system, and there are numerous moving parts in providing and receiving a safer care. I'm honored to have three distinguished colleagues here with me. They will share their thoughts on the critical role of healthcare workforce in engaging patients. This is my pleasure to introduce Ms. Heather Gokey. She is the Vice President of Risk Management and Safety at Beta Healthcare, which is the largest medical professional liability insurer for hospitals on the West Coast and a workers' compensation insurer. She's a clinician, an RN nurse with a Bachelor of Science in Healthcare Management and a Master of Science in Safety Leadership from University of Illinois College of Medicine. I'm privileged also to introduce Mr. Robert Imhoff, President of the Hospital Quality Institute. He's a graduate of George Mason University in Finance and also holds a master's degree in Public Policy, Healthcare, and Political Science from University of Maryland, Baltimore. In addition, this is my pleasure to introduce Dr. Steve Barker. Dr. Barker serves as a member of the governance board of the Patient Safety Movement Foundation. He's the Chief Science Officer at Masimo Corporation and a Professor Emeritus of Anesthesiology at the University of Arizona and a Clinical Professor of Anesthesiology. He's a board-certified anesthesiologist and has been a tenured professor in both engineering and anesthesiology for over 30 years with more than 200 academic publications. I'm very excited to hear from our guests and learn from their wisdom and expertise. Heather, I start with you. Can you please elaborate on your role at Beta Healthcare for us so that we get familiar with your goals and objectives, please?
Absolutely. Thank you so much for having us today. Well, Heather Gokey, Vice President of Risk Management and Safety at Beta Healthcare Group. And as Sanaz mentioned, we're a medical malpractice and workers' compensation insurer, which brings the distinct advantage of bringing both patient and employee safety efforts together. We're often referred to as a patient safety organization because Beta is a liability carrier and also a workers' compensation carrier that kind of conflicts sometimes in views and philosophy. However, our view is that if we prevent harm in healthcare and improve quality, that helps us focus on both learning and trust, and that makes healthcare safer. All of our programs are building a foundation of transparency and open communication. And ultimately, that helps us to identify preventative strategies for our consumers, which are really our patients.
That's great. Thank you, Heather, for letting us know. I'm going to go to Robert. Robert, would you please let us know what are the top 3 patient safety issues that you see right now these days?
Sure. Thank you. And it's a pleasure to be with you all. Thank you for including me in this discussion. Reintroducing Robert Imhoff, and I am the president of the Hospital Quality Institute. We are the patient safety and quality arm of the California Hospital Association with over 500 members, not just in California, but in 21 states across the country. So my top 3 issues, or what I feel are the top 3 issues in patient safety right now. I'd like to be a little glib with you first off and say workforce, workforce, and workforce. That's too easy of an answer, but it is where our focus is. But I will say at the top of the list is workforce. The other patient safety issues that are concerning to us are why are we dealing with things such as CLABSI and CALDI and falls and pressure ulcers that we had a good handle on prior to COVID. They seem to have reared their ugly head again, and hospitals primarily are dealing with issues that we had focused on, we had accomplished, we had moved on from. We're now back to those basic sort of things, and having to address what we felt we had moved from before. And the final issue that concerns me is, I'm going to say, workforce, because I think without a strong workforce, without a supported workforce, without a workforce that is well trained, that is well cared for, you can have all the protocols, all the directives, all the mandates, et cetera, without the staff and the proper frame of mind, the ability to carry those things out become very difficult. And again, we can have the greatest thoughts and the greatest opportunities available in those areas, but without people being trained and supported in the right way, I feel they are for naught. And I, for those who are listening that say, well, he mentioned workforce first, yes, I mentioned it third also. So thanks again.
Thank you, Robert. Dr. Barker, you have a very interesting background, being an engineer and being a clinician, all the lessons learned from aviation that you have brought to medicine and how you practice yourself and your passion for accuracy and handoff communication. Would you please let us know how important is communication between the caregivers, patients, and their families, and why this topic is so critical and important in providing a safe care?
Well, yes, thank you, Sanaz. And I'll start by saying the three of us are, and then plus you, the four of us, are a very interesting group with kind of diverse viewpoints, and I mean, our perspectives are different, and if you put them together, I think you come up with something hopefully very useful. Yes, as you mentioned, I was an aeronautical engineer long before I went into medicine. I actually got my PhD in that subject from Caltech, so I was a bona fide nerd long before it was fashionable to be a nerd. I taught aeronautical engineering at UCLA, and later went to med school and became an anesthesiologist. And in that second career, I do tend to look at how problems and solutions from aviation could be useful and applicable in anesthesia in the operating room. And I have to say, I'm proudly, in recent years, I'm not the only one who's doing this. If you look at the work of Atul Gawande, his famous book, The Checklist Manifesto, he's a surgeon. So to answer your question, the number one cause of preventable harm in hospitals, according to the Joint Commission, is failure to communicate, communication failures. And these take a number of different forms. That is also has got to be in the top 2 or 3 causes of major aviation disasters. And so we can look at the problems and the solutions from both disciplines, and I'll talk a little more about that as we go along. But to summarize, the Joint Commission has called this out as the number one cause of preventable harm due to medical errors, communications.
I go back to Heather. Heather, how do you promote patient engagement in healthcare? What are your thoughts on that?
You know, I love that Dr. Barker talks about communication because it is core to what we do in healthcare. And being a clinician, we know it's really important to respond empathically to both patients, families, and caregivers. So to Robert's point, the workforce is really important. One example is that in 2016, we launched Beta Heart, which stands for Healing, Empathy, Accountability, Resolution, and Trust. It was modeled after Candor, and many of you are probably familiar with that, the Candor Project. But we call it our comprehensive, systematic, and principled approach to respond to patients and families and caregivers that are impacted by harm in healthcare. And we believe that essentially communicating in truth and in transparency that allows us to really commit to trust and trusting relationships across the board, not only with our workforce, but also with patients and families when they've been harmed. Our holistic approach really focuses in on voice and the ability to feel psychologically safe in the workforce for bringing up things that are defects in our system, but also the voice of the patient. We believe that voice at all levels really promotes culture change within organizations. And you know, patients and families can really offer a lot of critical insight to what we believe is our environment and the way it operates, and we believe we've designed it in the way it should operate, and ultimately can really teach us a whole lot of things. So identifying defects that really exist in our workplace and set our workforce up to fail is really kind of threefold. We look at the workforce and their voice. We look at patients and families and their voice and what they have to offer. And then we also look to system design, as to Dr. Barker's point. System engineering is very important to us in terms of looking at defects. I think that 4 things that really need to be in place in order to get us to that point of communicating openly, honestly, and with transparency, and then fixing the issues in the organization is really to evolve our ability to communicate effectively. We need a really strong framework, a supportive system that allows us to really kind of put these processes in place and to really listen. So when we listen, we learn, and ultimately we need to learn in order to fix the things that are going wrong in healthcare.
Heather, this is wonderful. These 4 elements that you've mentioned, the ability, the framework, the supportive system, and the process, they collectively form a foundation to elevate the voice of patients. And can you please take us into the depth of this model that you have proposed and you're working on at Beta?
Sure. So we believe we really need to build the ability to communicate effectively. You know, we're not always trained as clinicians to really communicate with empathy, and even though, you know, clinicians are typically compassionate, that's really what brings us to healthcare. We don't always design messages and communicate those messages effectively to patients and families. And again, this doesn't come naturally to everyone. I think that there's a skill set, a very critical skill set to learn, that we need to take another's perspective oftentimes. And that requires us to kind of build that skill set in order to hear what patients and families are telling us, and then act on that which is being told to us. So in the context of harm, and of course, that's what Beta Heart is really kind of focused in on, is that view requires a unique set of skills. First, we need to acknowledge feelings. We need to understand another's point of view. We also need to remain curious, and we need to avoid the role of being the fixer. So oftentimes, you know, we're there to heal, help, and move things along in healthcare, but we can't always fix emotions. And oftentimes that's something that is really kind of lacking in our ability to communicate effectively. It takes practice, and we offer a Beta experiential learning in order to develop that skill set. And, you know, this helps hone individual skills and dialogue with patients and families when they've been harmed, especially when there are really emotionally charged, uncomfortable, and uneasy situations that we encounter when patients have been harmed.
Thank you so much. This was really eye-opening. Robert, you are really passionate about workforce, and I love to hear more from you as what keeps you up at night when you think about the issues that you have experienced with patient safety in healthcare?
Before I answer, I just want to add something that we are proud partners with Beta Health in the Beta Heart program. I can't say enough nice things about the program itself, about the faculty, about those that administer the program. As you just mentioned, is something very near and dear to my heart. When we studied partners and look for collaborators for our members, it was hands down with Beta Heart and Beta Health and the wonderful work that they are doing, and we are just so proud and delighted to be part of their equation. So back to the question, what keeps me up at night? Very simply, the escalation in workplace violence issues. This is in situations around the country. We hear all the time of the horrible things that happen to healthcare providers nowadays, to the point of being murdered. There's constant physical and verbal abuse of healthcare workers today. And again, goes back to that situation of how do you have a prepared workforce to carry out very important responsibilities and duties under circumstances like this. Our healthcare workers are afraid to go to work. Our hospitals are worried about how we properly protect them while still having a nurturing and caring, healing environment for our patients. It's a very fine line between having security practices such as magnometers and armed security guards, et cetera, while you're trying to establish a caring, healing setting for the patients. Attitude and perception is very important and in the healing process. And when you put things in a different light with extreme measures like that, and sometimes very necessary measures, it creates a whole different situation. The fact, again, that healthcare workers have to go to work feeling afraid and feeling pressured and not knowing what's going to occur is very unsettling to me, both as a patient safety professional, but also as a human being, that others have to endure these kind of situations when they're there to help heal and take care of all of us. We'll all access the healthcare system at some point. We want the safest, highest quality care available to us. And it becomes very difficult when you have to address situations like this. And it's something I would like to see reversed. It's something that the Hospital Quality Institute is working on. It's certainly part of our Beta Heart program and something that Beta Health is addressing. But right now, that is what really affects me and keeps me up at night around patient safety.
Thank you for sharing with us. Indeed, this is really saddening to see the situation with the workforce and the violence happening. Dr. Barker, coming back to you with the question in regards to the handoff communications and communications, as you illuminated the critical role of having a good, clean, concise communication method between caregivers and patients. How can we help improve these communications from both sides? And where do usually the failures occur in handoff communication?
Okay, well, that's an excellent question, which I've spent a fair amount of time investigating, and others too. Again, I think we need to take a lesson from aviation. We need a systematic method to ensure that communications are consistent and complete, and to make sure that we don't, as I describe it, forget stuff that is potentially critical. Aviation learned that the hard way through many accidents that I have reviewed, where they simply forgot stuff that they were supposed to check before takeoff, for example. That led to the heavy use of checklists, which I will talk about more in patient communication. But first, I want to mention that communication it's not just the doctor, for example, asking questions of the patient. It's two-way communications. The conversation has to go both ways. And, the goal is to get the patient to understand the doctor's perspective to the degree that they possibly can. And then that will help the patient think of facts that gee, the doctor might want to know that I had a stroke 10 years ago, or something that wasn't in the chart, or that I'm allergic to sulfa drugs, and the other party that needs to be involved, I stress this a lot, is the family. Because oftentimes the patient, in many cases, you can't communicate with the patient. It's a trauma case. They're brought in from a motor vehicle accident. They're unconscious when you first meet them. Hello, we're going to the operating room. I wish I could talk to you. But perhaps you can talk to the family and have the same conversation with them. So I guess to summarize the answer to your question, we want to ensure that it's two-way or three-way if we're involving the family, that people can ask questions from both sides and feel that they're equal parts of this communication process. And that, with some of the other tools that I will get to, that will help us avoid the trap of, as I said, forgetting stuff, which there are so many sad cases in medicine, as in aviation, where somebody forgot to ask an important question, the important information wasn't transmitted, and the patient came to harm or even death as a result. So that's what it's all about. Systematic method.
Absolutely. Dr. Barker, on that note, can you identify and let us know what's the most critical type of patient care communication? Because we want to make sure that we don't fail that part.
Sure, that's a very good question, and it's the one that I have spent the most time studying over the last 10 years. It's what's called handoff communications, where the patient's care or care responsibility is transitioned. It might be from one doctor to another during, for example, a shift change in the hospital. It might be from one unit to the other, and one that I especially was interested in was the emergency room to the operating room. Again, the middle of the night trauma patient, you come from the emergency room to the operating room in a hurry. And literally the handoff, as the anesthesiologist, I'm the receiver of that handoff, trying to find out everything the emergency medicine physician knows. And I'm doing that handoff while I'm literally running alongside a gurney that I'm helping push from the ER to the OR. And I have literally less than 60 seconds to complete that handoff and to get all of the information. So it's handoffs. This was identified again by the Joint Commission as a crucial source of errors. We identified in our Patient Safety Movement Committee work group at least 18 different types of handoffs that we studied. There are more actually, but we broke it down to 18. As I said, shift change, one ward or unit to another, specialty to another, when somebody goes down to radiology for a study, I have cases of that where the handoff was incomplete and disaster resulted. And again, there are about 6 different handoffs that involve the operating room as either sender or receiver. In each handoff, you have a sender and a receiver, obviously the one transmitting the care and the one receiving the care. And again, like I said, in communications in general, handoff communications must be two-way. It's not just the sender talking to the receiver. It's got to be a two-way conversation so that they understand one another. And where possible, not always possible, where possible, the patient is a third-party participant in that handoff. The patient's there give their point of view if you can. So, yeah, we've spent a lot of time studying that, and I think we've made some progress. Other uh, other organizations outside of the patient safety movement are also studying this problem, and I'm glad to see that.
Robert, I'm coming to you with
Yes.
2 questions at once. So there is no doubt, I think, in our minds and all of us that workforce play a really critical role in patient safety and in improving it. Can you give us your insight in the importance of this factor related to patient safety? And at the same time, can you please let us know the type of improvements that you've seen in patient safety throughout your career for many years and your experience?
Well, extremely close. And as I kind of alluded to when we were the previous question, we expect safe, quality care when we go see a physician, when we're admitted to a hospital, clinic, wherever. That becomes very difficult when you have a workforce that is under the pressure in situations that they are today. And as I mentioned with the workplace violence issue, overscheduling, staff shortages, all the things that we're dealing with today, many as a result of the COVID-19 situation that we all had to deal with. We lost 20% of the healthcare workforce because of as an aftermath of COVID. We had a number of physicians, nurses, et cetera, that kind of threw their hands up and said, "I've had enough. I can't do this anymore," and have moved on to other careers or just left the the practice of medicine altogether. You now have hospitals employing well-intentioned but undertrained staff. So to get them up to snuff, to get them to the point where they're efficient, effective healthcare workers will take some time. Those are all patient safety issues. When you have impediments to delivering safe, quality care, many of which I've just mentioned, then you have patient safety issues. It makes communication difficult, which we've talked about a great deal in this conversation. How to effectively communicate, when to communicate, what are the expectations around communication. That becomes that and other practices, other methods. It all becomes very difficult when you have a workforce, again, under the stresses and pressures that our workforce is under today. I think we've done a lot. I think we've learned a lot. And I'm going to go as a starting point, as many of us do, back to 1999 with the To Err Is Human report. That was kind of the advent of the patient safety movement within this country. I think we've done a lot, again, learned a lot. We have a lot of wonderful people, well-intentioned, very intelligent people working on this situation. And I think we've moved the needle in some respects a lot. Look at, as I mentioned before, CLABSI rates and CAUTI rates, et cetera. At one time, hospitals performed very well in that regard. We're in a different situation nowadays with a lot of hospitals. But by the same token, for the investment that we've made in this effort over the last 20 plus years, around 30 years, I guess, around patient safety. I think we still can come a lot farther, and we should be a lot farther than where we are. We have invested countless dollars, countless man hours in addressing this situation. You would think with that kind of investment and that kind of effort, that we would certainly be farther along than we are. So there is a bit of a disappointment, at least from my perspective in that regard, but it doesn't dull the commitment or the dedication that so many people have in making healthcare safer and higher quality for everyone. So I am optimistic. I am hopeful. But again, I think we have shown improvement in certain areas, but I think there are more areas that we could have improved more in. So I'm hedging my bets on this answer.
That's wonderful. Thank you, Robert, for sharing with us. Dr. Barker, would you please let us know what tools can be developed to improve these communications and make them more reliable?
Yes, thank you. There are a number of tools, but number one at the very top of the list, again, from my orientation in aviation, has got to be the use of checklists. Checklists are lists of tasks that you must perform in a given job to reach a goal. And it's very important that you don't forget any of these. And this was developed in aviation to prevent pilots from skipping crucial steps in starting the airplane or making an approach to a landing, and there were many cases that accidents that when they're analyzed, it was apparent that the pilots were distracted by some trivial thing that happened unrelated to the flight. It may not have even been important, but these distractors, they're called, take your attention away from what you were doing, and then you forget the next step and you skip it. So the use of checklists can prevent that. As I said earlier, Atul Gawande is a surgeon who has brought that into surgery and has actually shown good outcomes. I'm trying to bring it into care in general and in particular to handoff communications. And so our approach in the patient safety movement is for each of those 18 different handoffs that I mentioned to you in the hospital, 18 types of handoffs where you have a sender and a receiver, we come up with a checklist. And at each item in the checklist, the sender needs to look at it and make sure they address that item, and the receiver also needs to have that checklist in front of them and make sure that item was answered to their satisfaction. And that's why I said earlier the handoff is not one-way communication, it's two-way communication, or perhaps even three-way if you can involve the patient. If you look at the startup checklist for a Boeing 747, a big complex airplane, it's actually 2 pages long from the time the pilot and the co-pilot sit down in their seats to the time that they release the brakes and start the taxi. 2 pages of items to check. There is no way in the world that any human being could remember all of that every day, especially with distractors happening. And the same is true in medicine. It's gotten more complex. As you know, the good news, we've developed more science, better medications, better monitoring, but the bad news that comes with that is it's gotten more complicated, and there are more things to remember and more opportunities to, as I said, forget stuff. So the use of checklists is my primary tool that I recommend for handoffs. And just to complete the answer, these checklists might be on a piece of paper that you have in front of you. They might be on your iPhone or your device. They might be actually talking in your ear. Think about the example I gave you earlier where I'm literally running alongside the gurney as the gurney is going from the emergency room to the operating room. I can't be looking at a piece of paper, but maybe I have a computer that's talking in my ear, reminding me of what the next thing is on the checklist. That's the kind of checklist of the future. So those are all of the ideas that we're developing in the patient safety movement, and I hope to see those enacted soon. Thank you.
Thank you very much for sharing, Dr. Barker. Heather, would you like to also talk about the handoff, whether a handoff communication or tools such as checklists, and what your thoughts are in how they will be able to create safer healthcare systems?
Absolutely. You know, I totally agree with Dr. Barker in that there's so many distractions, and oftentimes it's difficult to remain mindful of information that we need to share one to the other when we're handing off care. checklists are a great example of an excellent tool that is absolutely applicable in healthcare and could be used to really not only give the information and communicate that information effectively, but also it sort of promotes the psychological safety between disciplines, between levels or a hierarchy. And it allows for still that communication to kind of get brought across to those that need to know, and enables us to actually act on the information in probably a more mindful way. What was interesting about Dr. Barker's point earlier about communication and this two-way communication, not only with patients and families, but also across the workforce, is that what I find often is that we're not practicing humble curiosity in ways in which we could, where we might be able to learn more. So I was just reading this article yesterday, day before yesterday, on something that was really trying to promote emotional intelligence. But it struck me such that it was really about being humble and being curious. And so when it came right down to it, the recommendation was to ask ourselves, or at least remind ourselves, that whatever we're hearing, there's something we don't know. And so to say to ourselves, either internally or even externally to patients and families, what is it I don't know? That allows us to kind of pause for a moment, become mindful, and gather more information, or at least give the opportunity for that individual to communicate what else they haven't said, what else they haven't given in terms of additional detail. Just like the example of stroke, oh, I had a stroke 10 years ago. Well, that's good information to know. So, so that is kind of something that I thought, I really need to put that into practice. What is it I don't know? And go into the conversation believing that as well. There is something here I don't know. So that's where I would say that it's really kind of looping back around to create the culture of voice that's necessary in healthcare, which allows psychological safety to kind of transfer across. Both patients and families may not feel safe enough to speak up or feel as though they're a little bit rushed because the physician has somewhere else to go, the nurse might have another task to do. And so we cut off information, prematurely close sometimes those conversations where we might learn more information that would enable us to act in a different way. So, so that's what I think is really important there on that point.
Heather, what would you consider as barriers that you anticipate when engaging patients and families? What you just mentioned about how we are really trying to elevate their voice is so critical, so important for us to have that mindset as people who are in healthcare, that there might be something we don't know. So humbling. But what are other barriers that you may see when you want to engage patients and families?
Well, I think sometimes it just boils down to fear. I think that, we are taught as clinicians to go in and sort of take control of a situation where we can deliver care and deliver it in the most effective and efficient way, and be perceived as that person in control. And sometimes we need to relinquish that control in order to listen and hear what others are saying in the room. We also know, and I think a big barrier is that, to Robert's point, is, we just came off of COVID. We in healthcare are really expected to show up 100% every day. But the healthcare workforce is human too. And the moral injury and the emotional exhaustion that exists right now in healthcare is something really to be paying attention to. I think that not every life is filled with ease, even in the most best circumstance. People go through divorce, they have sick children, they might have ill parents, they might be those, caring for their aging parents, other worries that exist. And so, so to think about what it is that we don't know, about those individuals is really important. I think in the end, really, it's about grace and giving grace to others, and that works both ways. Patients and families may not show up 100% either, given the stressors that they're encountering. And we need to also be mindful, take that patient's perspective when we're engaging in communication, and also take our workforce perspective when we're engaging in that communication as well.
Absolutely wonderful to know. Robert, how do we make significant improvements in patient safety going into the future, in your opinion?
Well, and I hate to be myopic or very narrow in my focus today, but you're giving me the opportunity to do so, so I'm taking it. I really think we need to focus more on strengthening our workforce. I think that is the foundation of patient safety. I think Dr. Barker made a great point. I'm going to use this because I speak on this topic frequently around distractors and people having to remember something without a checklist and the impossible or the difficult task of doing that. But let's look at the distractor on a more comprehensive level, and all that healthcare workers are dealing with as distractors toward providing safe care. Again, are you afraid to come to work because of a workplace violence situation? Or have you been through a difficult a harm event or a near miss and not been supported, and that's hanging or weighing heavily on you? As you go forward in your days of the practice of medicine, are you overworked? Are you overscheduled? Those are all significant distractors as far as being able to administer safe, quality care to the patients. So I think we need to make more of a focus on those things. I think we need to support the workforce in a much stronger and a much greater way than we do now. Not only is it the thing to do to ensure or to help ensure that we have safe, quality care, but come on, we're in the healthcare business. We're in the taking care of business. We're in the healing business. We're in the doing for others business. Let's focus on the family, as it were. Let's take care of them. Let's heal them. Let's help them. Let's support them so that they can do the job that we're expecting them to do. And without that, I think, again, all the wonderful checklists, all the wonderful protocols, et cetera, are not as meaningful as they should be. So I think the future and the improvement in patient safety starts with supporting, taking care of the workforce and being there for them, making sure they're trained, they're supported, they're helped, and they are healed and they are nurtured.
On that note, I want to share one thing, that one of our shared values in the Patient Safety Movement Foundation, and we have a couple of them, one of the most important ones is to bring joy, humanity, and diversity in healthcare. And I think that's what our healthcare workforce are individuals who have dedicated basically their entire life to caring for other individuals, and as a community and a society, nationally and globally, we have to recognize that, and we have to give them the support that they also deserve in this. Dr. Barker, can you elaborate on how we can measure the effects of communication changes that we make in our healthcare organizations?
Yes, that's a very good question, and it's not an easy answer, because when you make a change in how you do things, for example, adding a checklist, it's very difficult to do what we like to do in outcome studies, which is a double-blind, outcome where you have half the patients do not have the new therapy, half the patients have the new therapy. The person doing the study, if possible, is blinded, doesn't know which is which. Clearly, you can't do that with communications. So the outcome studies basically have to be before and after. We have data for how many times some data anyway, how many times failures to communicate cause patient harm. We enact something new, for example, a checklist for handoff communications. We restudy all of those data again and see if we had any benefit. The problem with doing before and after outcome studies is there's a lot of other things that may have changed in that time period, and you don't have any control over those. But despite those limitations, some outcome studies have been done. Again, I referred to Dr. Gawande, the surgeon. He's actually done an outcome study on the effects of his what he called the Checklist Manifesto. That was the title of his book. I strongly recommend it. It's on Amazon. You can get it on Kindle. He did an outcome study and showed that it had a beneficial effect on the number of intraoperative and immediately postoperative complications if you followed his intraoperative checklist. And I will add, he's got a very difficult audience to convince. Surgeons, they're used to being the captain of the ship. So we need to do those studies. But to summarize, they are difficult to do. I also just want to refer to something Robert said, and that is, how is this affected by our changes in our stresses in the workforce? Because it clearly is. We're going through a difficult period right now with what in anesthesiology anyway we're referring to as burnout. People get tired of all the garbage they have to put up with. Part of it, for example, might be all of the time you spend on the automated electronic record. And, many physicians have complained about this, that they're spending more time on the automated computerized record than they are with the patient. That's a major distractor. Patients have complained about that. So, that's something else that we need to look into and address. It does affect handoff. It is a communication problem. You can't communicate with the patient if you're sitting in front of a computer, typing into the computer the whole time, when the patient's actually in the room. I think that contributes to burnout. We need to study this effect. There is a shortage already, and it's going to get worse in anesthesia care providers. And we need to address that before it becomes critical. I think this is happening in other specialties too.
It was my absolute pleasure and privilege to learn from three of you. Thank you so much for sharing your insight. I want to open it up to our panel here. If you have any final thoughts that you'd like to share with our audience, the floor is yours. If there are final statements you'd like to share with them, please.
I'm happy to share. I think that we really need to remember that failing to engage patients and failing to engage our workforce is our future care. I don't know about you, but I think I'll be a patient someday. And so we really need to attend to these matters now to ensure that we're delivering quality care in the future to both ourselves and to our families.
I think that was a great summation of what we've talked about.
I will just add to what Heather said. Yes, we will all be patients. I had a recent experience that involved a ride in an ambulance, and I ended up having an emergency laparoscopic cholecystectomy, which, if you're going to have an acute abdomen, that's probably the best thing to have. It was just a gallbladder. But I didn't know that at the time, and my brain is going through all of the possibilities, and I'm watching the care take place around me as more of an observer than a participant. I think all of us in medicine we need to have that experience. I wouldn't wish it on anybody what I went through, but boy, it does give you the perspective of what it's like to be a patient. As you said, Heather, we will all be patients someday, and we need to be able to get in the patient's shoes, to identify with the patient and anticipate what they need to hear and see from one, to improve the communications, but two, just make them feel better about their care.
Yeah.
Robert, Dr. Barker, thank you again on behalf of myself and the foundation for your time and for sharing with us your insights and your expertise.
Delightful to be
I hope you all
with
have
you.
a wonderful day.
Thank you all.
Thank you. You
Great
too.
talking with all of you. Have a good day.